Thank you again. This is the last of my 4 lectures. I'd like to thank you all for being so welcoming. I've really enjoyed my time here in Brazil. Today I'm going to talk about the medullary thyroid carcinoma guidelines that were published by the ATA in 2015. I have no disclosures, and this is the guidelines that was headed up by Dr. Sam Wells. So I don't have to tell this audience, but just to make sure we're all on the same page, medullary thyroid carcinoma is a neuroendocrine tumor. You know it's not from the same lineage as the differentiated thyroid follicular cells. It is in the parafollicular cells, and it accounts for about 4% of all thyroid cancer cases. Medullary thyroid carcinoma, about 75% of the time, presents as a sporadic case. That is, you can't find the gene mutation, and 25% will be part of an autosomal inherited syndrome, as we just heard. As you also just heard, that the inherited syndromes primarily are MEN2A, which you know consists of medullary thyroid carcinoma, hyperparathyroidism, and pheochromocytoma. Familial medullary thyroid carcinoma, where you only see medullary thyroid carcinoma, and MEN2B, which includes the pheomucosal neuromas and intestinal ganglioneuromas. So, as always, I'm going to start with a case. 53-year-old male presents with a 6-centimeter thyroid mass and enlarged 2 and 3 centimeter lymph nodes in the central and lateral neck by ultrasound. Now, this is actually controversial. I've been actually talking with people. In general, we would normally biopsy the lymph nodes and the thyroid mass. I think many of us are actually stepping back and saying, why do we need to biopsy the thyroid? That you really just have to biopsy the lateral neck node. And the reason you have to biopsy the lateral neck node is you have to have a positive pathology in order to do a lateral neck dissection. Even though they look abnormal in ultrasound, you would never send someone for a lateral neck dissection to remove all the lymph nodes unless you had a positive pathology. But in general, we do recommend doing a thyroid biopsy and a lateral neck node if it changes the surgical approach. So the recommendation in the guidelines is 53, that you need to do a pre-operative evaluation in all patients. You need to measure a CEA in calcitonin. You should measure a RET proto-oncogene. And I said, I guess in Brazil you do 5, and then some places do 8, 10, 11, and 13 through 16. If there are clinical features of hereditary medullary thyroid carcinoma, then as our previous speaker spoke, you should analyze the rest of the axons. You should exclude the chance of pheochromocytoma. The easiest and most sensitive test is a plasma-free metanephrine. If it's negative, you're actually definitely do not have a pheochromocytoma. The problem is that it's such a sensitive test, it is not a very specific test. We have lots of patients with low levels of free metanephrines who do not have pheochromocytoma. In that case, then you do need to do a 24-hour urine fractionated collection of urine for fractionated metanephrines and catecholamines. Now, the guidelines very clearly say that to exclude hyperparathyroidism, you only need a serum calcium. And I have to say, I'm going to interject my opinion that I actually, as an endocrinologist, can't assess a calcium by itself, that I personally need a parathyroid hormone. And I live in Boston where we have no sun, so I actually need a vitamin D also with that. So even though it is not part of the guidelines, my personal recommendation would be to get a calcium, parathyroid, and vitamin D. And that was a recommendation level A. So I'm not going to go through this because it was beautifully covered in the last talk. We do want to get the RET mutations. This particular patient was RET negative. He was sporadic. But if you know which RET mutation you have, it actually helps you guide what to look for. Oops, excuse me. So for example, in the MEN2B, which has a 918 mutation, it actually has the highest level of medullary thyroid carcinoma risk. That means the highest level of death from medullary thyroid carcinoma. The incidence of pheo is 3 stars. So in this particular list, 1 star for pheo means about a 10% risk of pheochromocytoma. 2 stars is about 20 to 30% risk, and 3 stars is 50%. So for example, in a mutation of 918, I'm definitely going to screen my patient carefully carefully for the evidence of pheochromocytoma and generally is not associated with hyperparathyroidism. CLA is the cutaneous lichen amyloidosis, which is the rash on the back of the previous slides, and then Hirschsprung's disease. So if you look at each particular mutation, for example, if you had a mutation that was in 768D, that in that case you have a moderate risk of medullary thyroid carcinoma, but your risk of a pheo and hyperparathyroidism, the cutaneous lichen amyloidosis, and the Hirschsprung's are negative. So what this helps you is it helps you predict what you need to watch for in your patient. And it does say it raises your level of clinical concern and actually increases your screening if you need to. So the recommendation 63 is that if you have a patient who you think has limited local metastatic disease in regional lymph nodes in the central and lateral compartments, then in the setting of no suspected distant disease, you do recommend a thyroidectomy and central neck dissection, and Electron will discuss this in much more detail in the coming lecture. So in this particular patient who has a sporadic medullary thyroid carcinoma, he underwent a thyroidectomy, a central neck dissection, and a left modified modified neck dissection. So he had a 5.5 centimeter medullary thyroid carcinoma with extrathyroidal extension and positive surgical margins, and he had 9 of 36 clinically enlarged lymph nodes that were metastatic with disease. Now, the next thing we're going to do is at a point after the surgery, and 3 months maybe is a little bit long, but certainly about a month after surgery, you do want to get a post-operative calcitonin level. And in his case, it was extremely elevated at 4,000, and the CEA was also elevated. So what this helps us do is, according to recommendation 69, is that post-operative calcitonin will help you determine what the risk of recurrent disease will be and how you're going to plan your long-term follow-up with that patient. So this is from the guidelines. So you have your basal calcitonin and CEA. If the calcitonin is unmeasurable, you can back off and do much less follow-up. Your follow-up is going to be a serum calcitonin and CEA and neck ultrasound. It may be only every 6 months or even once a year after the first year. On the other hand, if the calcitonin is high, greater than 150, that actually is very positive for a persistent metastatic disease. And in that case, you're going to get a whole series of tests to look for the disease. Neck ultrasound first, because that's the easiest. A chest and neck CT. You're going to look at the liver, either by a contrast, a liver protocol for the liver with a CT or an MRI. You're also going to look at the bone with a bone scan. If it's less than 150, and measurable, then you have to use your clinical judgment. You would say that if the calcitonin is 3 or 4, you certainly don't want to do this whole list of tests. On the other hand, if it's 125, you might go ahead and look for the metastatic disease with this testing. So just to look a little more simple, first you're going to do an ultrasound. If you have extensive neck disease, pre-op, and your calcitonin is higher than 150, you're going to do a CT with IV contrast of the neck and chest. You're going to do an MRI or a liver-specific CT for the liver, and you're going to do an axial MRI or bone scintigraphy looking for metastatic bone disease. It is not recommended in the guidelines to do a PET CT at this point. So in this particular case, going back to our patient, his neck ultrasound was negative. The CT of his neck and chest was unremarkable, but the CT of his abdomen showed a hypodense liver, pretty small lesion in the liver, but also a lumbar spine metastasis. So he's a T4A, N1B, M1. So this is his bone scan. You can see that he has lumbar spine disease, rib disease, and so you would call him probably a minimal M1. So it's a little bit controversial how you describe him, but if you call him a minimal M1, you would then continue to do some therapeutic maneuvers. So if that person has new nodes in the neck that certainly can impede respiration or invade local tissues, you might do a compartmental dissection to remove the tumor. But you know you're not going to cure the patient, so I would not do another radical neck dissection, for example, to remove lymph nodes. You're really trying to just remove tumor that will get him into trouble further on. And In the presence of M1 disease, you can do less aggressive surgery, as I said, and then you should consider external radiation therapy for the areas that the patient can get into trouble with. So, for example, in this particular patient, we radiated his spine to prevent vertebral collapse in the future. If you have a lot of M1 disease, then you do again consider doing palliative surgery just to make sure that there's no compression of the trachea or invasion of the trachea. And then that's the point where you start thinking about clinical trials or tyrosine kinase inhibitors. You think about local ways to manage the disease. So radiation therapy if there is a spine metastasis or a hip metastasis. So the recommendation for long-term follow-up is the post-operative calcitonin every 6 months to determine a doubling time. And then once you've established what that doubling time is, you want to follow it at 25% of that doubling time. So if I've calculated my patient has a doubling time of 24 months, then I should check a calcitonin and CEA every 6 months, which is 25% of that 24. If the calcitonin rises between 20 and 100%, you want to look for local disease because that's where most often it occurs. If it's, again, was lower than 150 and became higher than 150, you can go look for systemic metastasis. So this is something that you can actually get on the ATA website. It's a calcitonin and CEA doubling calculator, which is free, and you can put in the CEA or calcitonins based on the date, and it will calculate for you their doubling time. So both his CEA and his calcitonin had a very short doubling time of less than 4 months. So 7 months after surgery, he had a CT of his abdomen and pelvis, and it showed that his lumbar spine disease was stable because we had done radiation to it, but he had progressive hepatic metastases and a new necrotic mediastinal mass. Now, we could have predicted this was going to happen. If you look at the calcitonin doubling time, it is an independent measure of both survival and recurrence. So if the calcitonin or the CEA doubling time is greater than 24 months, then the risk of progressive disease at 1 year is about 14%, relatively low. But our patient had the doubling time of much less than 24 months. He fulfilled this prediction that he had progressive disease within a year, and that occurs within 94% of patients with a fast doubling time. So in terms of the recommendation of how you manage patients, so the after treatment is indicated if the patients have lesions in critical places, in the brain, in the femur, in the spine, someplace that if there were progressive disease, the patient would have a significant morbidity or mortality. If asymptomatic patients have small volume disease, and that's where many of our patients they have this very slow doubling, maybe every 2, 4, 5 years there's a doubling, and their calcitonin just slowly marches up with time. You actually do not require systemic therapy. You can just watch that patient. And then finally, patients with rapidly progressive disease, where you have an anatomic focus of growth, and your doubling time is less than 2 years, you really should consider other therapies. In this case, it's going to be systemic therapies, generally with tyrosine kinase inhibitors. It is recommended when the guidelines were written that you could guide your patient to a clinical trial, but currently in the United States that we actually have 2 FDA-approved agents. So it actually is harder to get people into clinical trials now. And the people you're going to recommend for these tyrosine kinase inhibitors are people who have large tumor burdens, are symptomatic, and rapidly progressive. So this is not for your low-level, slowly progressing patient. And the tyrosine kinase inhibitors, which I won't repeat because our previous speaker did it so well, actually has many, many targets. And one of the interesting things is that these tumors are malleable. What that means is that you use one tyrosine kinase agent and it works for a while and it stops working, you see tumor progression. What some newer studies have shown is that you can switch to a second agent, get some benefit from that agent. And what's really interesting, Schlumberger with the lenvatinib trial showed that you can switch them back to the first agent and they can be sensitive to it again. So it's a little bit of a game with these tyrosine kinase inhibitors. You use it for as long as it works. You may have to switch to multiple agents over the years. So the two that are approved in the United States is vantinib and cabozantinib. They're approved in the US and in Europe. Just to give you numbers, for vantinib, there was a 65 reduction in risk of disease progression, and the median progression-free survival was 22.6 months compared to placebo at 16.4 months. So to most of us, that doesn't sound very good. To the oncologist, if we have any oncologists in the group, that actually is a significant improvement in progression-free survival. Cabozantinib seems to be perhaps more effective. The progression-free survival was 11.2 versus 4 months for the placebo. And those patients who are alive and free of progression, that means not free of disease, but free of disease progression at 1 year was 47% compared to 7%. So what these agents do is they stop the tumors from growing. There may be some reduction in the size of the tumor, but your primary goal is really for it to stop growing and have the patients coexist with the tumor. Lenvatinib, which has been, there's been a lot of information in the press. Schlumberger has reported, I think, in the last ASCO meeting. There's completed a phase 2 trial, and it seems like it's a very remarkable drug, that 44% of patients had about a 30% objective response. That means 36% shrinkage of the tumor to the study drugs, but very quickly, within 3 to 3.5 months. So that's very fast. And he's the one that showed that you can use it as a second-line therapy, so use it after something else has failed. And then again, when this fails, you can switch to a different drug, and it seems to still work. So I think that there are many options for our patients with progressive medullary thyroid carcinoma. I just want to show you the classic waterfall plot. This looks at the best response over the study period. So a patient can get better and then get worse, and this is based on objective size of tumor. As you can see that virtually every patient has some response to the tyrosine kinase inhibitor. May not be prolonged and then may not be more for a year or two, but most patients do slow down the progression of disease and have some response to the drug. So the summary, early diagnosis of sporadic medullary thyroid carcinoma should be treated with electron will tell us, a total thyroidectomy and a central neck dissection. You really need to do a neck ultrasound in all patients to make sure there are not lateral neck nodes, and if there are, they should be biopsied to confirm malignancy prior to a lateral neck dissection. Pre-operative testing, we're always going to test for pheochromocytoma, hyperparathyroidism, and RET analysis. I have to say that you might say, well, if you have the RET mutation that doesn't have a risk for pheo, why are you measuring it? The reality is the RET mutation takes weeks and weeks to come back, and you don't want to wait that long before you send someone to surgery, so you do need to do the pheochromocytoma and hyperparathyroid screen beforehand. Patients with regional residual recurrent disease rarely are cured, so there's no reason to do heroic surgeries over and over again for the tumor. You do want to protect the airway. You do want to protect sites that could be that could have invasion and cause morbidity. And patients with distant disease are really incurable, but the disease can grow very slowly, and some disease that are growing do respond to tyrosine kinase inhibitors. And if they don't respond to the FDA-approved drugs, then I really urge you to refer them to a clinical trial, because there are many other agents that are being tested right now. And again, this is the revised American Thyroid Association guidelines from 2015. Thank you very much.